So that when you're out of treatment, after multiple pairings of these go on in treatment, when you walk by the bar, you don't go, let's go in, it's happy hour. Your gut goes, I don't think so. It attempts to move the decision about use to the involuntary part of the brain. Part of the difficulty with this is that there are certain booster sessions that are necessary, so that after treatment, after you haven't been drinking for a while, you end up having to go back to treatment and say, gee, I think I'll go up to the hospital and throw up. It is central that the client be motivated in terms of continuing this whole process. Something that sometimes gets mistaken for counter conditioning is anabuse therapy. I really think of anabuse therapy as a cognitive therapy. It works on the basis that if I drink, I'll get sick. And it uses a physiological promise or enforcer behind that. Anabuse is a medicine. The patient takes it every day. It blocks the breakdown of alcohol at the acetaldehyde level. This is a step that any of you goes through if you drink. It's just the metabolism of alcohol in the liver. And anabuse blocks the metabolism at that stage, and the acetaldehyde level is a very uncomfortable level. It produces various symptoms in people. It can produce nausea, vomiting, flushing, sweating, headache. It makes you feel sick. If you drink and you don't experience this, then that happens because your liver is functioning well, and it slams you through this stage. It doesn't let you stay very long in this stage in the metabolism of the alcohol. The oriental flushing response is probably also an example of this difficulty, some metabolic difficulty at the processing alcohol at this stage. I call it a cognitive therapy because it really relies on the patient's motivation. They take the medicine daily. It's a daily commitment to sobriety. It really mirrors the AA philosophy of one day at a time. When I take the pill each morning, I'm making a commitment that for that day I'm not going to drink, probably for the next couple days. And for a patient to enter this type of therapy, of course, there has to be a physiological screening, and they have to be healthy enough to tolerate the anabuse alcohol reaction in the case that they do drink. That leads into our thinking about agonist therapy, what we would consider methadone maintenance, and it's basically treatment for the narcotic addicted individual. This includes heroin and prescription drugs. Usually, according to federal law, it requires that the addict show a 2-year history of addiction. It follows the medical model, and it relies on the addict's need for the drug. This approach is philosophically opposed to drug-free treatment. Underline this. It's kind of like 180 degrees different or facing in the opposite direction from traditional or drug-free. The main payoff or goal is that it stabilizes the addict's adjustment. If we briefly look at the philosophical differences versus drug-free and methadone maintenance, in the one, substance abuse is a primary disorder. In the other, it's secondary disorder. Under drug-free, we think normal people abuse substances. In the methadone maintenance is more a medical model, a risk factor, a predisposition that some people need a chemical adjustment in order to function. In drug-free traditional model, under the character pathology that we often find in the alcoholic or the substance abusing patient, The addict is seen as a normal person. In methadone maintenance, the character problems that are associated with drug addiction are the result of societal prohibitions to use. If there weren't laws against using, they could remain healthy. With drug-free, health is achieved by getting the drug out. In methadone maintenance, health or normalcy is achieved through the use of a legal drug. As I've gone through these different models, I'm not recommending one approach as the only approach. But when you're dealing with a substance abuser, your philosophical position is important. The substance abuser, in their progression through the disease or through the habit or through the use of their substances, develops a heightened sensitivity in the interpersonal realm. It goes along with the use of the substance, the acquisition of the substance, the covering up of the substance, and when they walk into your office, they have antenna out in terms of what do you think about them. And if you have a negative bias toward the substance abuser, that's going to come through. They're going to pick that up, even if you're trying to cover it in some way. So, in summary, effective treatment. You have to have a link with the client. There has to be a client-centered focus, and there has to be a goal, a shared goal from the therapist to the client that is understood and the client can buy into. And this sometimes comes at the start of treatment, and sometimes it's negotiated through treatment. One of the counselors that I worked with for a long time, he said the first time he went into treatment, he went to the marquee at the program and read down the names of the PhDs and the MDs and the LCSWs in the program, and he basically said, one of these jerks should be able to teach me how to drink. Compliance with treatment is crucial in any of these models, whether it's compliance with the group norm in a TC, or whether it's compliance with taking the antabuse on a daily basis, or whether it's compliance in traditional model with going to AA meetings. Compliance is a central component of the program. The bad news, the good news, bad news together is that the absolute amount of treatment still shows a positive correlation with outcomes. What that means is whether you're checked into a 28-day program or into a 6-month outpatient program, the density of treatment correlates with your success. So the number of hours you clock in treatment activities relates to success. If you get involved in treating substance abusers, you'll encounter miracles, and they are wonderful to see. You'll encounter clients who you never thought would come off square one, and they turn their life around, and that's wonderful. And yet you also have to be willing to deal with the failures, to see people continue to trash their lives, their families' lives, and that sort of thing. My takeaway point basically is that I think that small changes in your client might contribute to cumulative generational benefits as they go back out to deal with their families and to deal in the community. Hope this has been helpful in orienting you to some of the ideas around treatment models. Thanks.